Good day, and thank you for attending Bionic's second webinar in our summer webinar series. Today's webinar is titled Use of Upper Extremity Robotics to Assist in Cognitive Gains, presented by Dr. Sherry Wallace. Dr. Wallace is a PT, TVT, and is a clinical research specialist here at Bionic, and is an expert in the use of robotics in rehabilitation. Dr. Wallace is a US-based physical therapist with over 30 years of experience in a variety of roles, including clinical education, management, and treatment in various settings with a diverse patient population and diverse managerial supervision experience. She has experience in CEU course development, presentation, education development for both corporate programs and facility-based hospital staff. Sherry joined the field of robotics with the intention of making a difference in pathology and implementation of therapy across the spectrum in order to maximize the therapeutic experience of both patients and therapists, while assisting with bringing therapy into the 21st century. Sherry's philosophy of treatment has always been use what works, and thus the use of robotics to achieve early mobility for clients who might not otherwise have a method of achieving functional activity seemed a good fit to assist with developing new and innovative ways to treat patients and achieve maximum therapy benefits. Finally, a few notes before we begin. At any time throughout this presentation, you'll be able to ask questions by using the question button at the bottom of your screen. At the end, we will answer all relevant questions to the best of our ability. And with that, now let's begin as I turn it over to Dr. Sherry Wallace.
Thanks, Lauren. I'd like to take one moment just to recognize someone who assisted with this development of this webinar itself, and that is Holly Mitchell. Holly is a master's level occupational therapist with 5 years of experience in acute rehab, outpatient, and home care. She also worked for a Boston-based robotics company for 2 years as a clinical manager, and so she brought some expertise to us for this webinar. So thank you to Holly. This webinar is an introduction to the research regarding cognitive aspects of upper extremity function and how robotics can potentially play a role in improving cognition. We start with a description of how cognition is impacted by stroke, then progress to how it is hypothesized that the missing link in translating robotics to function is possibly cognition. We then discuss how to incorporate cognitive aspects into robotic treatment, and then finish with research showing how robotics can be used to improve cognition in general, and then how the Inmotion robots may be used to improve cognitive status. Cognition and its effect on motor performance is an underaddressed area in neurorehabilitation. Interventions to improve the relationship have been studied in very limited research. Cognition can have global effects on overall health and motor skills and may impact improvement in upper extremity performance if not addressed. From the research that is becoming more prevalent, we find the following. Among acute and subacute stroke survivors, up to 3/4 may demonstrate cognitive impairment from a study by Aprile. Cognitive effects of stroke are wide-ranging and may include impairments in attention, memory, visual perception, and spatial awareness. A recent systematic review on robotic interventions by Everard et al. Found that only 15% of trials enrolled stroke participants that had a cognitive impairment. 76% of studies excluded participants with cognitive impairment, and this study looked at 66 different articles. A study by Aprile in 2021 found that 50% of their sample of stroke survivors showed an impairment in attention, and approximately 30% of subjects with damage to the right hemisphere and 50% of subjects with left hemispheric damage showed impairments in spatial exploration. And last, stroke survivors with moderate cognitive impairment are 6 times more likely than survivors without cognitive impairment to transition to incident dementia. This from a study by Merriman. Cognitive impairment following stroke can affect motor performance through ideational apraxia, impaired problem solving, and basic task sequencing for basic ADLs or BADLs, or impaired executive function for instrumental activities of daily living, or IADLs. Some examples of this relationship will be detailed throughout this presentation, including in a pilot study by Fazoli, significant Fuglemeyer upper extremity gains were found from admission to discharge and at the 1-month follow-up assessment with the group receiving robotic therapy and ALPS, or Active Learning Program for Stroke, strategies, outperforming robotic therapy and task-oriented training, the standard of care for cognitive rehabilitation in upper extremity. Aprile et al. Found in 2021 that there was a relationship between upper extremity motor recovery and cognitive impairment. This study supported that robotic therapy, when supported by sensory feedback and cognitive goals, may improve treatment outcomes. Another study by Aprile in 2020 found that cognitive impairment improved following upper extremity robotic therapy in reference to visual spatial skills and attention through upper extremity robotic therapy. And a study by Ranzani in 2020 found that a trial group of acute stroke patients receiving robotic-assisted neurocognitive hand therapy, when compared to a control group, performed superiorly on the Fuglemeyer upper extremity test. Before examining the research, we should review the aspects of cognition that are currently being studied in conjunction with robotics. One example is the Oxford Cognitive Screen, or OCS, seen here in the slide. It was recently developed with the goal of describing and assessing cognitive deficits after stroke. The scale consists of 10 tasks listed here on the slide within 5 domains: attention and executive function, language, memory, number processing, and praxis, a form of critical thinking that comprises a combination of reflection and action. The Oxford Cognitive Screen was designed to be inclusive and unaffected by either aphasia or neglect, common deficits in stroke pathology. Because of this, it has greater potential to assess cognitive function in stroke patients in comparison to other tests, such as the Mini Mental State Exam or the Montreal Cognitive Assessment, which were originally designed to assess dementia. As seen in the figure from the paper by Main et al., the relationship between post-stroke motor, cognitive, and affect deficits and the complex interaction between them is shown here in the slide. In many cases, stroke-induced neuronal damage manifests in varying degrees of motor, cognitive, and affect impairment. These impairments can have standalone, debilitating effects, but each can also negatively influence the rehabilitation efforts targeting other domains. And recovery of one factor may indirectly benefit the restoration of the other two. Accumulating evidence suggests that improved cognitive functions like attention result in the recovery of upper and lower limb motor control, possibly due to better patient engagement. Similarly, the affect-related factors like depression and anxiety are known to have a huge negative impact on patients' daily lives. All of these observations demand the exploration of a holistic rehabilitation plan that might achieve more than additive outcomes by synergistic interactions between the motor, cognitive, and affect systems, which are potentially addressed by using robotic treatment. We'll return to this concept in a little bit. In this study, titled Influence of Cognitive Impairment on the Recovery of Subjects with Subacute Stroke Undergoing Upper Limb Robotic Rehabilitation, the study aim was to analyze the relationship between cognitive impairment and the functional outcomes of a robot-assisted upper extremity treatment in stroke patients. Treatment consisted of 51 subacute stroke patients, screened first using the Oxford Cognitive Screen for cognitive deficit status, and then assessed both pre and post-treatment using the outcome measures of the Fugl-Meyer assessment for upper extremity, or the FMUE, and the Modified Bartel Index, or the MBI. The treatment included 45 minutes of robotic activity 5 times a week for 6 weeks, for a total of 30 sessions using multiple upper extremity robotic systems, including the Amadeo, Diego, and Pablo by Tyromotion, and the Motore by Humanware. The table from this study, shown here, gives the percentages of patients obtaining a pathological score on the Oxford Cognitive Screen at baseline. In particular, the highest percentage of pathological scoring was detected in the category of number processing, as measured by the calculation task, at about 70%, followed by the category spatial attention, as measured by the Hart's cancellation task, at about 60%. This then was followed by language, memory, and executive functions, as measured by sentence reading, episodic memory, and baseline score tasks, respectively, at about 50%. Lower percentages were found for praxis, as measured by the imitation task, and about 25%, and perception, measured by the visual field task, with only 1 case occurring in this study. As seen on this slide, the improvement in motor function, as measured by the Fugl-Meyer, was statistically significantly lower in patients showing cognitive deficits in the following tasks on the Oxford Cognitive Screen: semantics, number writing, Hart cancellation, and space asymmetry, thus showing their impact on motor recovery. Next slide. Similarly, as seen on this slide, the improvement in the activities of daily living, as assessed by the Modified Bartel Index, was lower in patients showing a pathological score in the object asymmetry and the executive function baseline score, showing how cognition status can impact ADL performance. As an example of utilization of a treatment paradigm to address both upper extremity limitations and cognitive deficits, we present the study by Susan Fazoli and Catherine Adams-Dester, titled A Paradigm Shift: Rehabilitation Robotics, Cognitive Skills Training, and Function After Stroke. In this study, the researchers set out to improve upper extremity performance using ADLs by utilizing the principles of motor learning and exercise-dependent neuroplasticity, incorporating what they term an active learning program for stroke, a method of combining robotic treatment with active problem solving, salience of trained tasks, and strategies to facilitate the transfer of acquired motor skills to the use of the paretic arm and hand during everyday tasks. This development of concept Aprile is the first to test an active learning program that shifts robot-assisted therapy away from an impairment-focused intervention to one aimed at facilitating the transfer of robot-trained motor skills to functional use of the paretic arm. and hand after stroke. This new paradigm is based upon principles of experience-dependent neuroplasticity and cognitive strategy training, and it embraces the distinct strengths of robot-assisted technology and clinician-driven interventions. The rehabilitation robots deliver a higher dose of repetitive task-specific training than is possible in conventional rehabilitation settings. For example, in the case of the Inmotion robots, we know from the research that repetition counts of up to 1,052 repetitions are possible in stroke treatment within a 60-minute session. The clinician then empowers participants with a step-by-step problem-solving approach to facilitate use of trained motor skills during meaningful everyday activities, thereby adding salience and transference to the rehabilitation process. In the above research, the aim was to pilot and test the feasibility of a novel therapy protocol, the Active Learning Program for Stroke, also called ALPS, designed to complement repetitive robotic-assisted therapy in the upper extremity that is paretic. Treatment consisted of 10 participants. They were divided into two groups, the robot therapy group and the robot therapy task orientation training group, not discussed here. The treatment included 60 minutes of therapy, 2 to 3 times a week for 6 to 8 weeks for a total of 18 sessions. The results showed a statistically significant improvement on an impairment scale, the Fugelmeyer, and a functional scale, the Wolf Motor Function Test, for the group receiving robot treatment. The significance here is the improvement on the functional scale. In conclusion, the ALPS protocol was the first to extend cognitive strategy training to robot-assisted therapy. The intervention in this development of concept pilot trial was feasible and well tolerated, with good potential to optimize paretic upper extremity performance following robot-assisted therapy. In another study by Ranzani et al., the investigators set out to evaluate whether robot-assisted therapy of hand function, following a neurocognitive approach, combining both motor training with somatosensory and cognitive tasks, produces equivalent improvement in impairment to conventional dose-matched neurocognitive therapy alone. Treatment involved 33 participants divided into two groups, a robotic neurocognitive therapy group and a conventional neurocognitive therapy group, each receiving 120 minutes of therapy in 15 sessions over 4 weeks. The robot group performed 45 minutes of robot hand therapy using a technique combining a neurocognitive somatosensory feedback task requiring object discrimination and hand function. At the end of intervention, and upon testing at 8 weeks and 32 weeks post-treatment, the robotic neurocognitive therapy group showed significant improvement on the Fugelmeyer that exceeded the minimal detectable difference. The researchers concluded it is possible to utilize robotics in place of the intensive hands-on therapist component of neurocognitive intensive treatment of the upper extremity and still get the same results to increase the overall dose of treatment to achieve functional improvement. Returning to where we began with Main et al., from the paper BCI for Stroke Rehabilitation, Motor and Beyond, the figure here shows a conceptualization of the comprehensive and personalized program for post-stroke motor, cognitive, and affect rehabilitation. In a perfect scenario, every stroke patient would receive a comprehensive rehabilitation program simultaneously targeting the motor, cognitive, and affect impairments. At admission, the patient could be evaluated with an all-inclusive battery of clinical and neurophysiological assessments resulting in biomarkers to indicate the severity of impairments. Then the type intensity, and duration of the individual rehabilitation could be personalized according to the needs of each patient. This kind of holistic program with neurophysiology guided fine-tuning may help patients to achieve the best possible recovery. Now that we've considered the effects of cognition on performance and improvement in robotic therapy treatment, let's look at how treatment with robotics can improve cognitive function. In another study by Aprile et al. In 2020, researchers endeavored to determine the impact of an upper extremity robotics rehab intervention on cognitive function in patients after stroke. Treatment included 51 participants treated for 45 minutes, 5 times a week for 6 weeks, a total of 30 treatment sessions, using, again, multiple upper extremity robotic systems, including the Amadeo, Diego, and Pablo by Tyromotion, and the Motore by Humanware. Testing was done both pre and post-treatment using the following cognitive assessments: the Oxford Cognitive Screening, the Symbol Digit Modalities Test, the Digit Span, the Ray Osterrieth Complex Figure Assessment, the Tower of London Test, and the Stroop Test. We will be discussing the results of the Oxford Cognitive Screen only in light of time. Excluding perception with only one patient impaired, the domain with the lowest percentage of patients showing a pathological score was praxis at about 25%, while the highest percentage of impaired patients was found in calculation at about 70%. After the treatment, patients improved in all the investigated cognitive domains as measured by the selected cognitive assessment scales. Moreover, motor and disability scales confirmed the efficacy of robotics on upper limb rehabilitation in patients with stroke. The results suggest that robotic therapy can be used to combine motor and cognitive exercise. The figure here shows the pre and post-treatment scores on each of the tasks of the Oxford Cognitive Screen as an example of the results obtained in this study. Note that patients improved on all tasks in each of the domains of the Oxford Cognitive Screen, but those that showed statistically significant improvement were episodic memory in the memory domain, calculation in the numbers domain, and Hart's cancellation, a visual spatial assessment in the attention domain. All of the other tests showed significant improvement as well. The question may be asked then, why is this important? The interesting progression of rehabilitation programs is that more and more of them are including robotic systems as part of their treatment, but not many programs have focused that energy on inclusion of cognitive treatment per se. In looking at the missing link between motor performance improvement and functional outcomes, it's important to incorporate the latest research into our treatment programs. And the research is showing that incorporating cognitive treatment into everyday therapy could provide that missing connection to function. Taking the principles we've discussed and applying them to the use of the Inmotion arm and arm hand, we can make recommendations about how to incorporate cognitive training into use of the robot. General use of the visual aspects of the device utilize cognitive skills of visual scanning, motor planning, and processing speed and attention to task. We can add cognitive complexity by increasing the complexity of the task through randomizing the targets, fanning the targets, either north hemisphere, south hemisphere, east, or west, as seen here on the right-hand side, or even changing the location of the screen in relationship to the patient. The screen actually adjusts left and right so that you can put it either onto the patient's side that they have improved therapy responses or into the side that has neglect. Another way to add a cognitive challenge is by changing the targets to an actual graphical representation and adding a verbal component to continue the process of dual tasking. This can be done by having the patient perform additional language tasks like naming, either with singular descriptors or two-word descriptors. They can also categorize or name opposites. We can also add an additional dual task by having the person name objects found in a kitchen or have the patient name a different object in the category with which the target is touched. To simplify tasks, a patient can be asked to count as they are hitting targets or indicate directional information for up, down, right, and left. There are two different graphics modes on the device, one for adults and one for pediatrics, but it is possible to use both with adults. Just be sure to let the patient know that you realize the images are designed for children. The use of the program titled curl perturbation provides targets in a random pattern with the robot providing a force or perturbation to the arm as the patient reaches to the target. This requires the patient to plan and adapt their movement pattern to overcome the force of the robot while maintaining stability at the target for a 2-second hold. Performance of this task requires visual scanning for the random target, processing speed adjustment, and motor control to maintain the target for a 1 to 2 second hold. In addition, the therapist can challenge the patient cognitively by having them count as they reach a target in a sequence. So 1, 2, 3, change, repeating the sequence with each new target attained. Or having them identify things that might cause a perturbation as they touch a target, like bumping a door or tripping. To increase attention to feedback, the pathway or the P key, as seen here, can be used to give greater visual cueing. This additional visual cue can be used on most of the activities as well. A sensory feedback loop can be used by having the patient attempt to identify the direction the robot is trying to push them as they are reaching to each of the targets. The maze adds another visual component to the use of the Inmotion system by having the patient find their way through a set maze pattern. The targets come up in a set order, and the patient uses visual scanning to find the next target and then plan a motor path to reach it. To add a verbal skill to the performance of the task, a patient can be asked to count as they progress through the maze, name something in a specific category as they reach targets, or identify the direction they need to move to reach the next target as they are performing the movement using directional statements like up, down, right, and left, or north, south, east, and west. This is four-way paddle. This activity requires the following cognitive skills: visual scanning, processing speed, motor planning, and visual spatial adjustment and attention. The level of difficulty can be adjusted using the menu option to reduce the number of paddles, increase or decrease the size of the paddles, or change the speed of the ball, either making it more complex or less complex. There is an additional feature of haptic feedback that occurs with the paddle hitting the ball as well. Additional cognitive skills can also be incorporated by adding a verbal component of naming the color of the paddle as it hits, or listing the direction the ball goes as it's coming off of the paddle. Additional verbal activities could include naming activities like counting in intervals, listing words or activities in specific categories like kitchen objects or gardening tools. In obstacle training mode, the patient controls a car that needs to go through openings called gates in the walls that are moving toward them. The walls can either move in a horizontal or vertical direction. The cognitive skills required for this activity include visual scanning, processing speed, and motor planning similar to the four-way paddle. This mode also includes haptic feedback to the hand, but this time it occurs to indicate the error of hitting the wall. In addition, the therapist can gain insight into a patient's perception by noting whether the car is hitting primarily on the right or the left side, or at the front of the car, indicating a potential visual deficit or speed of processing issue. However, if the patient is primarily hitting at the back end of the car on the wall, it could indicate lack of attention or inability to maintain stability. In the squeegee activity, the patient is asked to clean off a fogged image to reveal the picture behind it. Information about a patient's perception can be gleaned by asking the patient to first clear an individual object on the screen, as seen here, and then to follow directions to clean the rest of the screen in specific directions, the various squeegee shapes, to see if a patient can plan a motor activity and then execute the plan. The pictures are arranged randomly, but some of the images are singular objects in a background to simplify the tasks. In others, the image is made up of multiple objects to make the visual scanning more complicated. Patients can be asked to find a specific object to clean off, or to perform the most efficient method to clean the screen. To add a verbal component, a patient can be asked questions about the images on the screen, or even relate the image to their own life and tell a story about a similar circumstance. In conclusion, the neurocognitive approach focuses on both the training of sensory motor functions and cognitive improvement while performing robotic treatment to increase repetition and thus increase neuroplasticity. Motor imagery is a technique that includes mentally rehearsing a movement of the affected body part, either with or without actual motion. Using the Inmotion arm or arm hand in active assist mode while performing motor imagery for those patients with limited motor function can combine both activities into one treatment to optimize treatment time and improve functional outcomes. In addition, the Inmotion systems can incorporate movement across all possible movement patterns of the shoulder and elbow while working on active problem solving, attention, memory, and sequencing. The main cognitive features of the Inmotion treatment are task sequencing and trail making, visual imagery, problem solving, and short-term and immediate memory, visual spatial skills, and executive functioning. Thank you all for coming. I will now turn it over to Bill for questions.
Thank you, Dr. Wallace. As mentioned at the beginning, you can use the question button at any time to ask a question. We had several questions come in during the presentation, and I'm going to allow another minute for anyone else who might have a question on today's topic. Questions. Dr. Wallace, the first question is, what is the easiest way to incorporate cognitive rehab into the use of the Inmotion system?
Yeah, that's a great question. So the cool thing about it is that you can add cognitive applications by just adding a verbal component. So when the device is in use, you can add dual tasking by just having the person name an object if you use it in graphics mode, or having the person list something within a category that you've given them. So like we said, you could use kitchen objects. So they name knife when they go to the north direction, or they name fork if they go to the east direction. So you can make it directional, or you can make it just random. Within the squeegee mode, it's as simple as having the person talk about the pictures that they see on the screen, and that, or either having the therapist ask questions about what gets revealed behind the fog.
Second question is, why doesn't the research show improvement in functional outcomes after robotic treatment rather than impairment improvement?
Yeah, so this is one of the big issues that has come up since robotics started to be used, particularly for the upper extremity. Many of the early robotics research used the Fuglemeyer as the main measure of outcomes. And the thing is that this Fuglemeyer is specifically designed to measure impairment, not necessarily function. And so when they started incorporating things like the Wolf motor function test, they were not seeing the same kind of results with those tests as they were seeing with the Fuglemeyer. So one of the things that they started to hypothesize most recently is that the missing link here could potentially be intention. So we know, and which is obviously a cognitive activity. So we know that most upper extremity activities of daily living require some form of intent. And that is a cognitive skill. And so the thought process is that that's the missing link between connecting the activity that you gain by having somebody do robotics and then applying that to function.
Does the Inmotion system have assessment features that address cognition?
So here, it's important to understand what the purpose of the Inmotion system is. And the Inmotion system was originally designed to assess motor function of the upper extremity in kinematics and kinetics. So here we're talking about how the arm performs, not necessarily how the person perceives what's on the screen. So currently, no, there is not an actual test to perform to get a cognitive outcome on the machine itself. But most of the time, therapists are running a cognitive assessment of a patient as part of their therapy program. And my suggestion would be that we start looking at this Oxford cognitive screen because it is specifically designed for individuals with stroke. That may be a more beneficial cognitive screening than, say, the Mini Mental or the Montreal.
How can this device be integrated into retraining ADLs or related upper extremity motor skills?
Yeah, so this is where the ALPS protocol that they talked about becomes pretty important, in that it's very difficult to take a robotics device unless it's mobile and you can perform ADLs with it and actually do that. So the suggestion would be that you use the device more as a warm-up. So we are getting the patient ready to move their arm in a new way. And then following that, we would perform a functional activity using one of these cognitive-based skills for the patient to really analyze how they're performing the task and then come up with ways to improve that so that we're adding a cognitive element and an intent to our training rather than doing it strictly by us giving instruction to a patient.
Very good. Does an occupational therapist have to specifically treat cognitive deficits to use the Inmotion system?
No, this is one of the great things about it. All devices that require you to look at a screen are going to have some form of cognitive input because there's visual scanning that has to occur. And of course, the patient has to respond to something that is occurring on the screen. So just by doing the robotics activities that are included in the device, you're already adding cognitive elements. The recommendation would be, though, that we take this one step farther and that we start to apply neurocognitive approaches to our treatment after using the system, or that we start to incorporate, when patients are appropriate for this, things like dual tasking and verbal skills at the same time that we're using the robot. But no, you can use the device without having a cognitive element at all.
The last question is, do you have a link to the article about neurocognitive therapy applications?
Yes, and anyone that is interested in any of the articles that we discuss as part of this, those articles, luckily enough, all of the references that we use are open access. So I don't tend to use papers that you guys can't get access to. And so there is a reference list on the presentation. And if you go to our website, this presentation will be on there, and you can actually look those up. And each, like I said, each one of those is open access. So you can actually pull their paper.
Well, thank you again, Dr. Wallace, and also special thanks to Holly Mitchell for her input.
Yes,
And
very much so.
Thanks. And thank you all for attending today's webinar, the second in the Bionic Summer Series. As a note, today's webinar will be available on Bionic's website. Just ask for your patience. It'll take us just a little bit to review it, edit it, and get it posted. And please remember to register for our 2 remaining webinars, the guiding treatment of neurological impairments with robotic data in upper extremity rehabilitation, and Inmotion Connect, driving clinician adoption of robotic assisted therapy and enhancing patient outcomes. So thank you again for joining us today, and I hope you have a good rest of your day. Thanks.
Thank you.